right, welcome everybody. Thank you for joining us today. I think a few might trickle in, but we'll get started with those that are here. As a general reminder, we wanted to just ask everybody to send any questions to the Whova app. We'll have time for questions at the end if you enter them into the Q&A section, or you can save your questions and unmute at the end during the question time, and we'll address anything at that time. So anybody who was present for our breakout session yesterday was able to hear about speech therapy best practices for assessment. And today we're going to focus on intervention. So I'll go over some pediatric considerations and case examples and then pass it over to Sarah, who's going to talk about adult considerations and examples. And then we'll both kind of touch on the next steps for management in this evolving era of SMA care. So during yesterday's breakout session, we talked about assessment of swallow function and the high rates of aspiration in patients with type 1 SMA. So after the assessment is complete, if severe dysphagia and aspiration is identified, it's going to be really important to complete a risk assessment with the multidisciplinary care team to determine if proceeding with any oral trials should be a part of the patient's care plan. We likely need to be more conservative than with other patient populations we might work with, as even a small amount of aspiration could really have pretty catastrophic effects in some of our SMA patients overall, just due to their low respiratory reserve and their less effective cough to clear aspirated material and secretions. So it's really important to perform that risk assessment and take that particular patient into consideration and their risk factors and variables that may be coming into play. So after your assessment, if you've identified that this patient may have either a mild dysphagia or no dysphagia and not at a significant risk of aspiration, your treatment is probably going to be continuing on an oral diet, making sure they're continuing with consistent swallowing practice, depending on if they have a supplemental feeding tube in place or not. If it's safe, we want them to continue to be eating if that's something that's enjoyable and pleasurable for them. For our young patients, we're really kind of guiding and helping to support them through the progression of developmental feeding milestones, because they might be reaching those milestones at a different rate than their age-matched peers, and helping to guide parents to determine when their child is developmentally ready and not just age-based recommendations for moving through feeding milestones. We'd also be guiding modifications to diet as needed and determining when instrumental reassessment of swallow function is needed, and monitoring their swallowing safety with any signs of disease progression. For a patient who maybe had an assessment that identified significant dysphagia or aspiration risk, this is where that risk assessment comes into play, and figuring out if therapeutically they could still be continuing with small volume swallowing practice if that's part of their goals of care and safe at the time. And that might change. They might be safe at the beginning, but if there's decline or changes in their respiratory status, you might need to reconsider at a later date. So this might be even as small as just 1 ml sips of water, or just some pleasure taste, just to keep the swallow mechanism active, and mostly only if this is enjoyable and pleasurable for the patient as well. Some patients with severe dysphagia, it's not enjoyable to eat, and others really do want to continue to some degree. So you really have to know your patient individually as well. Other goals might include more active secretion management and just tasting practice for some oral sensory exposure, or even just being involved in family meal times for the social experience that comes along with meals. We talked yesterday about how decreased tongue strength is a common deficit identified in SMA patients. So therefore, our treatment plan may include some direct exercises for tongue strengthening. So if we improve lingual strength, we could subsequently see an improvement in bolus propulsion and transit through the oral cavity, and a reduction in oral residue. And if we improve tongue-based retraction, there's also a potential to reduce residue in the vallecula. One way to address tongue strengthening is with the Iowa Oral Performance Instrument, often referred to as the IOB. This can be used for resistance training, and it can also provide biofeedback. For really young patients, it might not be appropriate, but for a slightly older child or young adult into adulthood, this could be an option. For our younger children, your therapy might really be focused on just getting them comfortable placing the bulb in their mouth, and that could take a long time to get a child to voluntarily complete this task. Once they're comfortable, or for an older patient who it's not a concern, then they can start to use their tongue to push up on the bulb, set a threshold, and work towards a treatment plan. If you aren't familiar with this device, this graphic on the right shows how you can place the bulb and do essentially a tongue press up against the bulb, and the unit will give you a nice objective number to be working towards. Another thing we talked about yesterday were deficits in jaw opening. So patients with SMA do report issues with mouth opening, and we see on this chart that as depending on the type of SMA, we are seeing some higher rates of reduced maximal mouth opening. So therefore, jaw opening could be part of a patient's treatment plan as well. This could be done formally with a tool like the TheraBite, if you're familiar with that, or for our younger patients, sometimes it's much more informal, working with different teething toys that are different sizes, and getting them comfortable putting different sized objects in their mouth and working towards a wider mouth opening. It really depends on the age of the patient and what they're receptive to, but you can do it in a somewhat more informal manner, trying to get placement of a slightly bigger and bigger teething object further back into the molar region, and that will indirectly kind of help with their jaw opening. And then we also talked yesterday about difficulties with chewing, commonly seen in patients with SMA. So this study was specifically about SMA type 2, but we do see this across the spectrum. There's reduced strength and endurance among the muscles of mastication, although not as severe as limb weakness. It can impact their quality of life and the quality of their chewing and ability to eat all the different types of solids that they want to be eating. So you can see that there was on the left chart, a statistically significant difference in maximum bite force for patients with SMA. And then the chart on the right shows maximum bite force duration was also shorter in patients with SMA. So addressing chewing as part of your therapy plan might be applicable depending on your patient. I want to highlight two cases. So the first is my friend here. So a little bit of background history before I show his swallow study video. He was diagnosed with SMA type 1 at 5 months of age and received Spinraza starting at 8 months of age. He had a G-tube and Nissen placed at 15 months, and then a trach placement at 16 months of age for a nocturnal BiPAP requirement. So I first met him when he came to our institution for Zolgensma, for gene replacement therapy, when he was 23 months old. He wasn't from the Boston area, so he came here for treatment. And when we first met him, we decided to do a repeat modified barium swallow study. So he had one done back in his home country when he was about 14 months of age, and that was that showed significant dysphagia, aspiration of all consistencies, and that's what led him to get his G-tube when he was about 14 or 15 months old. So this was a little under a year later, and we just wanted to see what his swallow function was looking like so that we could help to guide his treatment plan while he was with us. So this is his swallow study, and we only looked at puree consistency. And I'm gonna get a laser pointer so I can kind of show you what we're looking at. So I did actually have to edit out a lot of the frames early on. He had a lot of difficulty just with his oral transport of the bolus, so it actually got quite diluted by the time we have the bolus down in the vallecula and the piriform. So let me play that again for you all if I can. But overall, as we get back to the video, he really just could not initiate a swallow. He actually doesn't have any of the bolus move from the pharynx into the esophagus. He ended up needing suctioning to get rid of the bolus. It's not the best quality video because the bolus did get so diluted, but you can see he's having a pretty hard time initiating a swallow and getting any clearance. I wanted to show you just a video of him working in his PT session that his family sent me last week, so you could see how great he's doing. But really, we were seeing pretty significant bulbar dysfunction and swallowing impairments at this assessment. So for him, our therapy wasn't focused around eating. It was focused on secretion management. As he was getting a little bit older, he was more aware of his drooling. So we were working on just oral awareness and using a cloth himself to wipe his mouth. His parents were obviously still needing to do oral suctioning and tracheal suctioning for him, but just getting him more involved in his secretion management. We were letting him do a few small tastes, just like a spoon dipped in apple juice just for flavor, and some licks here and there, because he did enjoy it, but it was a fine balance because sometimes that did lead to increased secretion production, and we don't want to put our patients at any risk to be aspirating their secretions as well. So it's very conservative, a few tastes, but on some days where he was having more difficulty with his secretions, we had to dial that back. We did work a little bit on mouth opening and tongue strengthening with him. We talked to parents about a plan for when we were going to reassess his swallow function, but since he had two studies about 10 months apart that both showed pretty profound deficits, he wasn't someone that we were repeating swallow studies frequently with. And then we also were working on some communication, speech and language goals as well. The second patient I want to highlight is a little similar, but was more active in his oral feeding. So this patient, to give a little bit of background, was diagnosed at 2 months of age with SMA type 1. He came to our facility at 6 months, was when I first met him for risdiplam trial. So he was a full oral feeder when he came. He was exclusively breastfeeding. And up until this point, he had no overt concerns with his swallowing. During our initial assessment, he breastfed well. We did go over some positioning changes with mom just to get him in a little more upright of a position and minimize any potential aspiration risk. And we did a lot of parent education and provided anticipatory guidance about what families should be looking for that could indicate any sort of changes or declines in swallow function, and how they could identify some of those signs and notify us as soon as possible. He then went on over the next year or so that we were working with him. He was a little late to introduce purees. Parents were pretty hesitant because of his reduced head control, and he wasn't showing great developmental readiness. So a little bit later, we worked on spoon feeding, introducing purees. We worked on introducing a bottle and a cup because we did want to get an instrumental assessment on him, but where he was exclusively breastfeeding, we weren't able to complete a modified barium swallow study when he was younger. So we worked on different methods of delivery so that potentially we could work towards a swallow study if we did start to have swallowing concerns. We needed a different way to administer barium. And then he mostly was on a modified diet of purees due to delayed chewing, and we were actually offering thickened liquids from a cup as a strategy to help to control bolus size and slow bolus the flow through the oral cavity since he didn't have great oral control. So overall, we worked on positioning, bolus size, and the rate of feeding for him were his major feeding strategies during this time. We continued to clinically assess his swallowing, and he did have pretty slow weight gain, so he was working with nutrition during this time to make sure he was getting adequate nutrition. At 23 months of age, we did eventually refer him for his first video fluoroscopic swallow study or modified barium swallow study, because we're starting to see more clinical signs of dysphagia, where he was having multiple swallows per bolus, more throat clearing and wet breath sounds, and we were having a hard time getting him to advance it towards more textured solids. So this is his swallow study done at 23 months. So this is actually the same age as our first example. I realized as I pulled these videos, they were the same age at the time. But we were able to see quite a bit more swallowing for him. So starting with puree boluses, he was able to take, and most of his oral intake at this point was pureed. So this is pretty representative of what he was doing. You can see he has some pharyngeal residue, but is able to clear most of it with a secondary swallow. We wanted to look at thin liquids from a bottle, but really he never really engaged in a great sucking pattern, which was similar to how he was presenting clinically. So we moved on pretty quickly from that. And we wanted to look at thin liquids from a syringe, because this is how parents actually were getting a lot of his liquid into him. He was still breastfeeding a little bit, but after his purees, they were giving him a fair amount of water from a syringe, which we all know is not our ideal method of delivery. It doesn't, it's a little bit passive and doesn't give the child a great chance to have good control over the bolus, but we wanted to see it because that's what he was doing. And then we finished off with some sips from an open cup to know that with a larger bolus from an open cup, did that impair his airway protection at all, or was it something we could keep working on in therapy to get him to accept an open cup better? So overall, he does show deficits that were similar to what we see in many SMA patients, difficulties with bolus clearance, but he had adequate airway protection, so no aspiration was identified during his study. So we did feel comfortable letting him continue to eat and drink on his modified diet. And we continue to implement those feeding strategies, you know, eating in an upright position at a slow rate to give him time to take additional swallows to clear boluses. And we were clinically or therapeutically working on advancing his chewing skills with more easily dissolvable, meltable solids, so that we could continue to work on some chewing directly. Eventually, he was admitted about 6 months later with some respiratory distress. We repeated his swallow study then. It was similar to the previous one, but he did get a G-tube for supplemental nutrition during that admission, and started to work towards a reduced frequency and volume of oral trials. Similar consistencies, but supplementing through his G-tube to get him the nutrition he needed, because he was starting to become a little less efficient with his oral feeding as he got older. All right, so I'm going to pass it over to Sarah now. So I'm going to stop share, and I'll take any questions at the end as well.
Okay, thank you, Kayla. I'm going to try to do the screen share on my end. Hang on just a second. I guess this is a lesson learned here that we were all queued up, but let me try this again. Okay, can someone let me know if the slides are visible now?
I'm not seeing them, Sarah. It came up briefly, and then it was end of slideshow. So
Okay, let me try this again.
try again.
I'm seeing them on my end, but hang on just a second. And show.
There.
Are you able to, okay?
Yep.
Able to see anything?
Yep, that's perfect.
Okay, sorry about that, everyone. The powers of technology. But to segue from Kayla's excellent presentation and her case studies, I wanted to touch on a few other items regarding management. And again, some of this is applicable to infants, pediatrics, and adults. So for the first item, and Kayla mentioned this in her case studies, is one of the first and key components of swallowing management is diet modifications. Typically, these would be based off of our instrumental swallowing studies, like she had shown the modified barium swallow studies. And I wanted to bring everyone's attention to the increased efforts over the last several years to get more consistent descriptions of the various diet levels. So when I started practicing 25 years ago, every hospital, every clinic had their own diet levels, and some more differentiated than others. But over the last few years, there's been the International Dysphagia Diet Standardization Initiative, and I did put some of their graphics here. I'd encourage everyone to go to their website. All of their graphics are provided for people to use and copy in their current form to use. I put the framework on the one side where it delineates the food levels from more of a liquidized diet to a regular diet. And then there's the level of consistency for liquids from thin to extremely thick liquids. And I know this slide looks a little bit busy, but there are wonderful handouts on this website. So on the very left-hand side, I just took a sampling of 3 of the handouts for pediatrics. And then in the middle of the screen, there's 3 of the handouts correlating to the different levels for adults. And so some of the handouts, I will say, on the liquid consistencies are quite complex in terms of measuring liquid viscosity with syringes and things like that. But I really like the handouts on the foods, giving some really good ideas on how foods can be prepared, what foods would be excluded on some of these diet levels. And again, these are free reproducible handouts for our patients and families. I find those very helpful. And as we look at diet modifications, then this is also the time where the speech pathologist or feeding specialist would be very involved with the physician or nurse practitioner in discussing non-oral nutrition and hydration via a tube feeding. And so as Kayla had in her case studies, and I will present in mine, tube feeding is something that many individuals with SMA will have at least at some point in their lifetime. Swallowing management across the age range also consists of very individualized safe swallowing strategies. And so I put a sample of a sheet that I had typed up in general, and I make edits to individualize it for each patient. But these should be based on swallowing diagnostics, and not, again, a strategy that works for one individual may not be what another person needs to be using. So individualizing treatment across the board, then safe feeding strategies. And I think we alluded yesterday to the difficulty that that one has with feeding another person, particularly an adult. So that's, if you've ever tried that, it can be quite a challenge. And so working with the caregivers, families who might be providing feeding assistance. Positioning is a big aspect. So this is where we collaborate with OTs and PTs regarding just overall body positioning. And then some of the head and neck control issues come up. So how can we best position the patient's head in an upright or neutral position? We really want to avoid the hyperextended or the having the head tilting backwards during the swallow, as that just anatomically opens the airway or makes the airway a little bit more susceptible to aspiration. There's a whole range of adaptive utensils and adaptive feeding equipment. So I just put some of the items here. I think the nosy cups, which are in the middle of the screen towards the bottom, are very helpful. So again, the person that's taking the sip of liquid has their lips on the higher side, and that ridge is cut in the cup to allow the cup to be tilted with the cutout for the nose. So you don't have to tip your head back to take the liquid from the cup. Some other cups available just to limit bolus flow. So again, most patients will benefit from taking small single boluses of liquid or foods at a slightly slower rate. And so just having anything, even the basic Starbucks cup type model at the top there can help limit bolus flow. There's other modalities to management of swallowing. Unfortunately, we don't have a lot of objective data as to whether they are efficacious. And so tongue strengthening, Kayla mentioned the IOP. That's definitely something that can be trialed, although I have not seen the data for adult patients using the IOP who have SMA. A mouth opening is kind of an area that I'm exploring with some of my colleagues in clinic a little bit more, trying to collaborate with other providers at Stanford, finding out some options that might help our patients with mouth opening for eating, for oral cares, and even the challenge of having dental exams. For communication, we've got the whole range of individuals from speaking orally who might benefit from using more compensatory speech strategies. And this could be as simple yet as challenging as just slowing down and pacing their speech, improving the coordination of breath and phonation. And we'll see that in the adult example that I have. Cueing patients to over articulate as they're slowing their speech down so that they can maximize the oral facial function and movement that they do have. And then some of the concepts behind energy conservation. So many of our adults with SMA are actively involved in jobs, in college, in various settings where they can be actually quite busy. And so just for one of our individuals who's in the workplace, just the encouraging him to schedule his meetings and some of his high communication demand activities at a pace where he has just ever so small amount of downtime to kind of recalibrate from an energy perspective so he can maximize his communication. Voice amplification comes up for some of our patients. And so this is a voice amplifier there in the middle of the screen, although there's some smaller, even more low profile devices. These can be quite helpful. Again, it's just going to amplify the patient's own speech. So if it's already degraded from a dysarthria standpoint, that this will not help improve that quality, but it can give the voice a louder volume. And this is a tool that many of our adults are using very effectively in certain situations. In classroom environments or work environments, although all of that is currently on hold. Some of our patients are using it when they're on their Zoom calls. So those can be a very economical and effective way to improve communication. And then there's the much larger issue of augmentative and alternative communication. And this would warrant a talk unto itself, but this can be the whole range from low tech to very high tech devices. Low tech, so alphabet boards, communication books. I've got a few pictures there of samples. These are effective, I think, for all of our patients to have something low tech to supplement or use as alternative communication, depending on the severity of their dysarthria. It's great to have low tech available for that moment when some high tech options, like we saw here, technology can sometimes be difficult, and if we need something immediately, low tech is always a good option. But as with the boom in technology and personal devices that we all have experienced in the last decade or so, that really has translated to increased options for our patients. So many patients used to have a dedicated speech generating device. I have a couple of those on the screen for individuals, many of them with SMA that do not have traditional access to the computer. Eye gaze technology is very helpful. So that is a Tobii Dynavox device with an eye gaze panel in the middle of the screen. But what's most exciting, I think, for our patients is just the increased use of standard, traditional, commonly used devices, the smartphones and tablets. I think that also brings some normality, that we're all kind of walking around stuck to our devices, and they too can use these to help with communication. I didn't want to omit this topic in the talk, but one large area of management for SMA would be options for communication, as well as the impact of swallowing by having a tracheostomy. And the scope of this specific discussion is outside the time that we have today. And so I just am making brief mention of some of the speech options for tracheostomy. I strongly encourage anyone working with this population to have the specialty training that's required to safely and efficiently treat individuals that have tracheostomy with or without mechanical ventilation. So given that it's the airway, if this is mismanaged or managed incorrectly, that can lead to devastating and life-threatening consequences. So definitely have the background if you are treating an individual. I included the reference for a paper that we put out years ago. This is not specific to SMA, but it has the whole range of communication options for patients that are receiving mechanical ventilation, most of which are using a tracheostomy. And so there's some great diagrams within the article, and I encourage you all to locate that. I believe it's available. The full text is available for free online. And so just to highlight some of the options for communicating orally with a tracheostomy would be using a leak speech, where you're talking around the tracheostomy tube with a deflated cuff or a cuffless tracheostomy. There's the Passy-Muir speaking valves that can be quite helpful for patients who do not use mechanical ventilation. They can also be used with mechanical ventilation, but there the safety concerns start to escalate, and so you really need to do that with high safety standards. There's the capping of the tracheostomy, or certain trachs will have certain features that allow for oral communication. Now, this is just the avenue for getting the voice with the tracheostomy, which otherwise would be potentially blocking the glottis and the larynx. So this is producing the voice, but not impacting the quality of the oral articulation or resonance of the speech. But wanted to mention that here. And now I wanted to move on to the case example that I'm going to present. And interestingly, this is an adult patient. She's 38 years old, diagnosed with SMA 1 at the age of 6 months. And she's been coming to our clinic, as well as previously treated at an outside clinic with Spinraza. She, as you will see in these clips, is just meeting me for the first time. This is several weeks ago, and she reports never having met a speech pathologist in her entire lifetime. And so she does have a mask on for portions because this is in the peak of COVID here. I'm in full PPE gear, so my speech actually sounds quite altered because my N95, I believe, is pinching my nose quite tightly. I did put a transcript on the side. I played a little bit of her speech yesterday, but wanted to help us out here with a little bit of a transcript, and that will help, you'll see, with perceiving her intelligibility. But this is our patient talking about her communication and her tracheostomy. And if someone can jump in and let me know if you cannot hear her.
It's correct. I got my speech when I was 3, and the doctor said they didn't know if I'd be able to talk. Yeah. And I sure did. You did. Because I have to. Yeah. And so, do you mind if I just peek at which tracheostomy you have? Yeah, I have a ventilator and a trach. Okay, so a fairly small tube. Yeah. And you're speaking on leak speech, right? Yeah. Okay. Wait, what is that? The air is coming up around your trach tube? Yeah. Uh-huh. Yeah. I don't usually feel it until I go to sleep at night. Perfect. Perfect. Yeah. Any challenges with speaking with the tracheostomy? Sometimes the air sweeps around it and it's a little hard to understand, but I don't mind repeating myself. Okay. Did you ever work with a speech therapist? Never. Have you worked with or met one as an adult? No. You've done this all on your own? Yeah. Okay, wonderful. How do you rate your communication? Do your nurses and family and friends understand you? The people around me understand me. So I see people coming in. Sometimes I'll have to have my nurse translate. It depends on the person. Okay. Yeah. Are there any tricks that you use if somebody's not understanding you? I just suction my mouth a lot. Suction in your mouth? Yeah. Okay. It kind of helps. Okay. Does it ever help if you kind of slow down and get the words with each breath? Yeah. The timing. It's all about the timing? Yeah.
Sometimes I have her repeat or just tell me what letter it starts with. Like I'll play that game.
Wonderful. Yeah. So sometimes it's just the key word at getting the other person's brain on the right train of thought. Yeah. Yep. Do you use any type of communication board, or do you give the letter? You just give the letters. Okay. Wonderful. Yeah. Wonderful. Are you using any other devices like texting or? Yeah. I use my iPhone. Oh. And sometimes if somebody doesn't hear me, I'll just text them. Perfect. Okay, so hopefully everyone could hear that and the transcript helped a bit. But I think that, again, this is me meeting a patient who has many, many decades of SMA with all of these issues and has not met a speech pathologist. So I'm kind of doing an initial interview, but I wanted to use this specifically because it illustrates a lot of the points that we've talked about so far in our sessions. So this patient has a tracheostomy. She's speaking on leak speech. So that trach tube has a pilot balloon and a cuff that's deflated right now. So the air from the ventilator is going up through the upper airway around the trach tube. Interesting when I mentioned leak speech or kind of gave it a term that was unfamiliar to the patient. So it was interesting just meeting somebody where we were talking about the same things, but it sounds like she had not really spoken to a therapist about these items. So I'm not sure how she originally got to using leak speech. It works fairly well for her in terms of the intelligibility problems are primarily related to her articulation. I'm talking about compensatory strategies of slowing the rate. For her, it's beneficial to allow for maximal articulation, but also to coordinate with the breath that's coming from the ventilator. And then it highlights the use of multiple modality communication and some AAC, just in the sense of trying to get the keyword spelling, and like her caregiver throws out the letters, or she'll acknowledge what letter it is, but not using any type of formal communication board. And then the use of the iPhone, which our OT is working on a device to help the patient access her iPhone a little bit better, but overall the patient feels that she's doing quite well. And the patient rated herself, the VHI, as a 33 was the total score, which again implies that moderate level of voice impairment.
It's correct.
I'm moving on. This is the same patient. We've taken her mask off for a little bit. And again, I'm in my full PPE. And this is just a very short sample of her demonstrating some of her oral motor movement.
Go ahead and try to pucker your lips for me like you're giving a kiss. Yep. And how about a big natural smile? Perfect. And try just gently opening your mouth as wide as it will go. Okay.
So just highlighting some of those, that was just a brief snippet from our session, the very reduced oral motor range of movement that impacts both speech and oral intake. And now moving on to the swallowing. So I'm not presenting her actual swallowing study because she has not had one. Again, she's just meeting me for the first time. And this is the patient giving a little bit of history on her own swallowing. I've got the transcript there, and I also have her eat 10 up in the corner there, just for reference.
Wonderful. And then I wanted to ask you about your swallowing. So I do see that you had a feeding tube when you were much younger, and that was just discontinued when you were 18?
I didn't like it because it hurt, it always got stuck on my phone, so, and I love to eat.
Okay, very, very, very important information.
Yeah.
And so what's your typical diet consist of?
So I eat, basically everything has to be blended, and it has to be like a soup consistency. So I do that. I eat everything. I eat pizza, pasta, not so much, but everything else. And I usually do 2 nutrition drinks every day. That's a boost.
So did you say pizza?
Yeah.
Okay. So is the pizza blended so that it's the same texture as like a soup?
Yeah.
Mm-hmm. So it's not a liquid, but it's not even a puree.
It's like I add milk, I add chicken broth, and I blend it.
Milk and chicken broth?
And we strain it.
And strain it. Perfect.
Yeah.
Okay. And how, so you have feeding assistance.
Yeah.
How is it, how do you take it into your mouth?
I use a 60 milliliter syringe, and I put it in my mouth and swallow.
Okay.
So there's so much information that we gather just from those few minutes. So she, again, has not had a formal swallowing study. She had a PEG, but had it removed at her, per her own decision. She is somebody that does not want to have any further swallowing assessment at this time. She does not feel that she's having any airway issues in terms of aspiration. If she were to have an exam, given her kyphosis, she would not be an ideal candidate for a modified barium swallow study, just with the kyphosis. I believe the shoulder anatomy would obstruct a large part of our view. So she might be somebody who a FEAS would determine if she was getting any aspiration or laryngeal penetration. Her EAT-10 is a 13, and you can see that she rates herself largely as zeros on more than half of the items. Her functional oral intake scale would actually be close to a 5 because she's taking multiple consistencies, thin liquids and a slightly thick liquid, more like the boost consistency. And I think it highlights the issue of pleasure and quality of life that's derived from eating. So despite the blended liquefied pizza, that is something that she really enjoys and wants to continue. And then she alluded to the feeding by syringe, which as an adult therapist is something that I've never recommended it in my career, but you can see that perhaps that's something that's carried over throughout her lifetime, as Kayla's case presented with taking the liquids by syringe. So there's just a lot to gather from that, just that short interview with her. And finally, the same patient is now going to just go into a little bit more detail about the actual feeding issues, which this is again showing more of the change over the lifespan.
I used to use a little plastic lead solo cup that I can take using my hands. And then after I couldn't use my hands, I would have my knife assisting in taking out of the cup. And then I got a little bit lazy and I started using a syringe.
Okay. Do you feel like you have any choking or coughing while you're...
No, I don't really choke. I only swallow probably half of it, and the other half kind of just comes out.
It comes out the lips? Like drains? Yep. Okay.
Yeah.
And then what about the medications? How well are you getting medications in?
Usually if I'll take a little extra of it, or if it's a small amount, I can usually shoot it in the back of my throat.
Tell me that again, just a little bit slower.
Okay. I usually take a little extra
Yep.
of it, or if it's a little tiny amount, I can put it down the back of my throat and it's easier to swallow.
Okay, so somebody can put the medication way back.
Yeah.
Yep. Okay.
Because we have the tiny syringes.
Oh,
put it all the way
okay,
back.
but you're using the bigger syringe to eat with. Yeah.
Mm-hmm.
But kind of bypass the tongue part by getting the medication right back there. Okay.
Yeah.
Any medications that are hard to take? Connie mentioned like Metamucil. Maybe you're not getting the full amount.
Anything that's super thick is kind of hard to swallow.
Oh, we were talking about Miralax.
Yep.
That's what we were talking about.
Yeah. Kind of a little thicker. Like, I know that most people find it easier to swallow things if they're thicker.
Uh-huh.
No, I'm kind of the opposite.
You're the opposite.
Yeah.
So thicker is not easier. Okay.
Yeah.
And
So I know that was a little bit longer of a clip, but I think it's just, there's so much that we can gather from that information. And again, what quality of life and what pleasure with eating looks like to different people, and how we have to keep that in mind as we manage, and not just kind of come on in with all of our formal measures and expect patients to do things kind of by the textbook when they have something that they think is working for them. And so again, I'm just meeting her, but so much insight. And for her, the thicker liquids are not necessarily easier. So just keeping all of that that individual variation in mind. So with that, I'm going to turn it back to Kayla to wrap things up.
All right, thank you. So we wanted to wrap up almost with more questions than answers. I think when given the task of talking about best practice, I think we're still trying to figure out best practice in a lot of cases because SMA care is ever changing and evolving right now. So a big question right now is just what is the SLP's role in care, and what are these new therapeutic options? How are they changing the presentation of dysphagia and voice and communication needs in patients with SMA? So really, more recently, we've shifted from more of a palliative role to more of a therapeutic role, and our goals are starting to address more maintenance or even improvement of skills as we're seeing how these therapeutic agents are impacting and potentially preserving some swallow function. So next steps for the SLP who's managing patients with SMA is to really start thinking about when are we collecting a baseline assessment, and then what is our reassessment timeline, getting a standard assessment protocol across all clinicians in all settings who are treating patients with SMA so that we can really look at outcome measures and do some research on what effective interventions are for these patients. And then also education for SLPs in the community who might not have been seeing SMA patients at a high rate, but potentially now will be as some of these pharmaceuticals and therapeutic agents are becoming more effective and expanding the life expectancy for some of our patients. And then another question is really just determining new phenotypes for the different therapeutic options that are available, and which of these options are helping to preserve swallow function and bulbar function more than others. And I think that's something we're all still trying to figure out and learn, and that is eventually going to guide best practice, and hopefully we will have more developments in the next years to the next decade, and it's an exciting time to be working with these patients.
Most definitely.
And then we just put some contact information. I know yesterday we talked a little bit about both of these groups. So Dr. Caitlin McGrattan's lab out of the University of Minnesota, she has a special interest in SMA and is doing a good amount of research. And there's a bulbar function global working group working on developing a global scale to assess SMA patients. So if you're interested in either of these groups and you're treating SMA patients, just reach out to Sarah and I, and we can get you in contact. Here's our contact information if anyone would like to collaborate in any way. And if you have any questions, feel free to unmute yourselves at this time, and we can take any questions from the group. I think there was just one question that popped up on the Whova app. Sarah asked, in my second case study, when was he treated for SMA and what type of treatment did he receive? So he was treated at, what did I say, 6 months of age with risdiplam. So he came to our facility, he was enrolled in the Firefish study. So as part of that study, he received the risdiplam before it was FDA approved. And that was around 6 months of age. So that swallow study I showed when he was 23 months of age, he had been getting the medication for quite some time. Thank you so much for joining us today.